Okay, we'll start the meeting. Welcome all for the lockdown lecture series. Today we invite Dr. Anand Parthasarathy for our lockdown series. He completed his MBBS from the Armed Forces Medical College Pune and underwent residency at Arundhai Hospital Madurai. He completed 3 fellowships in refractive surgery, cataract and cornea from the University of Erlangen, Germany, Singapore National Eye Center and the LV Prasad Eye Institute from Hyderabad. So he is currently a medical director and chief surgeon of the Center for Vision and Eye Surgery in Chennai. Over to you, sir, for your lecture in the recent trends in keratoconus management.
Just give me a minute. I'll just share my screen.
So over to you, sir. Can you hear me?
I can hear you. I can hear you. Are you able to see my screen?
So you can share your screen and the volume is a bit closer. I think slightly you'll have to increase or come closer to the mic.
Can you see my screen?
Yes, sir.
It is indeed a pleasure for me to be here. There are many among you who have been either colleagues or my teachers, and it's an honor for me to be part of this conference. And I'd like to thank Dr. Venkatesh and the entire team at Arvind for allowing me to share my experience. Of course, we are in a time when we are learning a lot more in terms of keratoconus and of course newer additions to our vocabulary. So I practice in Chennai, not very far from Pondicherry, and no financial interest, though I'd like to have some. Just give me a minute. All right. Now, I guess in keratoconus, we talk about very similar outcomes for your picture on your left and right. Both require similar managements. You need to stop the progression, stabilize the bulge. You need to improve the contour through intervention, and you need to have measurable results. Just for the record, that is not me.
So screen share has gone, sir. I think you'll have to share screen again.
Is that okay?
Slideshow, sir.
So, as I was mentioning, that your picture on the left and right both require similar managements. You need to stop the progression, stabilize the bulge. You need to improve the contour through intervention, and you need to have measurable results. And when you look at interventions for keratoconus, broadly, you can do something in front of the cornea, that is specialty contact lens. You could do something on the cornea with collagen cross-linking combination treatments. You can do something in the cornea, which is rings, and you can do something beyond the cornea, which is phakic lenses and sometimes IOLs. I'll start with one case presentation, a government employee who underwent cataract surgery in 2011 and referred for a corneal problem for unsatisfactory visual recovery, and he was best corrected 6/18. And we actually did the scan. This is the right and this is the left. You could find that he had significant corneal ectasia in the center. And when we went back to the history, he had actually had LASIK about 8 years back And then he disappeared. By 2018, we had a new software. I had also become wiser. And when we put him on the topographer, you could find that he's got a fairly eccentric ectasia in both the eyes. And the amount of ectasia across the pupil is almost about 9 diopters. So he had post-LASIK ectasia, which was missed by the operating surgeon. We plan to do a TopoLink PRK in the right and in the left eyes. We plan to customize cataract surgery, which would be aberration adjusted. And you could see that when we put this patient on a topographer, and this is a TopoLink PRK available with the wave light, and if you can see my arrow, which actually shows the area of the ectasia, and when we plan for a topo-guided PRK, you are ablating the steeper part of the cornea with a focused laser beam. So there is more ablation. This is the area of the cone, and this is the aberration pattern, which shows that the steeper part of the cornea is going to get flattened. That is a bit of ablation in the periphery to take care of the induced myopia. And this is the other eye. As you can see, this is the scan of the patient, which is showing the ectasia. And this is the ablation pattern for this eye. And we did that for both the eyes. And this is the right. And you can see a fairly eccentric ectasia, which becomes fairly regular after treatment. And you have this patient can then actually wear a pair of glasses even, or a simple contact lens, which is toric, and you can provide him good vision. In the other eye, where the ectasia was very, very eccentric, you can still that there has been an improvement in the shape of the cornea, and he would then require a customized contact lens to improve his vision. And you make out the amount of ablation and the area of irregularity that has been treated by the laser. So it is possible to treat this very, very irregular corneas, and you can actually improve the vision. And when you put this on an eye trace, this was pre-operative, and post-operatively you can see an improvement. This is one other patient who has a fairly off the center cone, and after ablation, she is a lot more central. These are some of our results of customized ablation over a period of time, and you can see a lot of them have stability on follow-up. Of course, there are some pointers in post collagen cross-linking eyes. When you're planning something like this, you need to understand that collagen cross-linking is basically a biomechanical cellular process, hence unpredictable. You can do it, plan for an ICL, which is actually a refractive procedure, or a PRK. Remember that in post-CXL eyes, the ablation rates tend to be different, so there is a modification required for that. Now, when you're planning to do something like a phakic IOL in these patients, a stable refractive correction is important before you plan anything inside the eye. We do a fair amount of combination treatments, combining collagen cross-linking, intracorneal rings, ICLs, or PRK, and you can do a single sitting versus sequential. Remember that you need to combine it sometimes as a single sitting. Sometimes we prefer to do sequentially, usually giving about a 4 to 6 week gap. Now, there are some operative factors which affect the post-operative visual acuity, which include the epithelial protocols, the fluence protocols, the type of riboflavin used. There are, of course, some complications affecting vision, and it's also important to check if there is any previous treatment done for keratoconus. There has been a lot of talk about accelerated cross-linking over the last few years, and we have done a good amount of work on this. And now our preferred pattern is to actually either do a 3 milliwatt for 30 minutes, either with hypertonic riboflavin, or we prefer the 9 milliwatt with 10 minutes, which also tends to give very, very good results. Beyond this accelerated, the 18 milliwatt, 30 milliwatt, and 45 milliwatt, we have actually more or less discontinued. We don't really do these. So my suggestion would be, if you want to get a very significant effect, especially in patients with fairly advanced cones, a 3 milliwatt would make a lot of sense. A 9 milliwatt for early to moderate cones works pretty well as well. An important point of discussion over the last few years has been whether the epithelium needs to be removed or not. Remember, collagen cross-linking, probably the most common corneal procedure performed for keratoconus, and it's important that you have good success rates. There is, I think, no more discussion in terms of outcomes. We do know once you take the epithelium off, the penetration of riboflavin is significantly better because it's a fairly large molecule, And this histopathology, if you can see, shows that there is more compaction of the stroma in areas where there is significant epithelial removal. So if you want to get a very significant effect, removal of epithelium is preferable, and it's something I would advise. There are some operative factors which affect the post-operative visual acuity, and in terms of whether you should do it mechanically or using a transepithelial PTK, I don't think it really makes a difference, though the comfort tends to be better with the transepithelial PRK, and that is still my preferred option. I do use PTK mode in the laser machines I use before we go ahead with the procedure. There are some intraoperative, which is the fluence effect on the postoperative visual acuity, and a fair number of studies on this. Remember that you would get a greater change in keratoconus after indisease if you use the standard protocol of 3 milliwatts for 30 minutes. So if you want to get significant effect, it is better to actually plan for that longer protocol. The second important factor is, are there any intraoperative factors in terms of postoperative visual acuity? And the second most important factor that we use is riboflavin. When you compare HPNC riboflavin with dextran, you would find that there is actually not a big difference in terms of visual acuity, but on longer follow-ups, dextran does better, maybe because it tends to dehydrate the stroma a lot more. So if you're looking at longer term effect, dextran might be a preferable option, but the advantage with the HPMC riboflavin is that it does tend to give you a bit more of comfort in terms of thickness of the cornea. A second important factor are operative factors. Should you be looking at refractive correction versus topographic correction when you're combining these procedures? We have done a fair amount of refractive and topographic corrections. The topography tends to do well as well, but they do require significantly more visual aids in terms of contact lenses or glasses post-operatively. So I prefer to do a bit of both. I prefer to do a refractive correction in terms of reducing the irregular astigmatism, and also try and correct the most irregular part of the cornea with the help of the laser. This is something that we've been doing well over the last couple of years, since we have had access to the Schwind laser machine, which allows you to actually customize the abrasions of these fairly irregular corneas even more. So if you are got short of tissue, which is probably possible in fair number of corneas which are fairly advanced, where you do not have much of tissue to play with, in these patients, it's a good idea to actually customize the aberration that you want to correct. Remember, in keratoconic corneas, you do get significant trefoils, significant comma, and those are important, and irregular astigmatism. Those are important aberrations along with spherical aberrations to be corrected. The very high order aberrations beyond 5th, 6th, and 7th order may not really make a difference. Coma, spherical aberrations, and trefoils are three important aberrations, and we've done a fair amount of study where there is a very, very high value of these aberrations. So those need to be corrected in addition to the refractive correction if you're planning an aberration associated cross-linking. Now, this is a slide also which mentions that the newer machines allow us to customize the amount of epithelial removal that needs to be done. Remember that a lot of these patients have thin epithelium over the cone. This was a study done almost 5 or 6 years back by Dr. Dan Reinstein, who found that over the cone, the epithelium is actually thinner. So it is possible to actually modify the amount of ablation so that over the cone you ablate less, and around the periphery of the cone you ablate most. That allows you to customize the treatment even more. This is just to mention that over the cone you ablate less, and then it actually makes a difference. Now, it is important that you do not miss the contralateral eye, and we did present this almost 10 years back, where we found that in patients with contralateral eye tends to have irregular astigmatism, tends to have higher spherical aberration. So it's important that you always look excuse me, at the other eye to look for asymmetric keratoconus. In my experience, about 10% of patients tend to have asymmetric cones, where one eye would be fairly irregular and the other would almost be normal. Our collagen cross-linking results in pediatric has been fairly good. We have now almost about 36 months follow-up in a lot of these patients, and we find that the improvement in these patients is not fixed. It changes over time. So in a lot of these patients, there is an improvement in the Snellen's visual acuity, the vision uncorrected and the best corrected over time. But in pediatric, we are almost very, very clear that you need to plan to do the standard 30 minutes, 3 milliwatt protocol, because the effects are important. And in children, you would prefer to give the best possible treatment, which is guaranteed. When you're combining collagen cross-linking with intracorneal ring segments, it does tend to add-on effect. This is one of our patients who had uncorrected 5/60, best corrected 6/12, and we planned a combination of intracorneal rings with the collagen cross-linking in the right eye. And then she actually went off to US, but in a 3-month follow-up, you can see that over a period of time of about 6 months, the cone becomes more centered, and you can see it shifting centrally. This was a picture, a screenshot she sent to me from the US, where we find her uncorrected vision is actually improved to 636, and with a contact lens, she is 6/6 parts. So it is possible in a lot of these patients are fairly advanced that you can plan a customized intact treatment, combine it with a collagen cross-linking. Even a lot of these patients, we have actually additionally done some laser treatments to reduce the irregular astigmatism further if the corneal thickness allows. What we did, and her mother actually came back about 6 months after she left to the US, and we found that she had very, very significant irregular astigmatism, almost like a pellucid-like keratoconus. So it's very important that you screen a lot of these patients, put them on a topographer, their close relative brother, sister, maybe mother, father. And in this patient, her mother had very significant pellucid-like irregular astigmatism with cataract, for which we did a toric lens. So you can see that a lot of these changes tend to be hereditary, so it's important that you keep an eye out for that. This is the other eye of the mother, and you can see it's fairly bilateral with an irregular astigmatism. Now, how does the intacs work? It causes the displacement of the apex towards the central pupil. It causes corneal topography regularization. Basically, the prolate profile is restored. It reduces optical aberrations, improves visual acuity, and contact lens tolerance. Just to show a short video of how intracorneal ring segments are done with the present femtosecond lasers, it is actually very, very good, very, very centered. And we've not had any issues in terms of placement of the depth because it's a lot more accurate. Yes, when we were doing it manually about 8-9 years back, there were some problems in terms of depth, but a lot of these patients now with the femtosecond actually do quite well. The placement of the rings is fairly straightforward. Remember, you need to put, if you're putting asymmetric ring segments, need to put the thicker ring first, and then you need to put the second ring. Occasionally, if you follow the nomogram, sometimes you may need to put only a single ring just to make sure that you center the cone. Remember that these rings do not work in all of these intracorneal rings, do not work in all of the cones. They work better with central or maybe slightly eccentric cones. If it's fairly eccentric, rings may not be a very good idea in terms of centering the cone, though you may improve the uncorrected and the best corrected vision. This is one of my youngest patients. He's almost about 16 now. We did the surgery when he was 14. You can make out the arcus juvenilis and a very well-centered ring. He has both good uncorrected and best corrected vision, but you need to watch these patients fairly closely because of the associated allergies. There can be associated vascularization, and you need to follow them up and manage the allergy very, very well. As you can make out, the depth placement with the femtosecond is actually very, very good. And in this patient, we were able to get almost about 80% depth. And you can confirm that with an OCT showing the good placement of the rings. Now, we've had good follow-ups in a lot of these intact patients. And the aim is not to get them perfect uncorrected vision. They will have a good uncorrected and an improvement in the best corrected, on an average about 4.5 diopters to 6 diopters of spherical equivalent as possible. If you combine it with collagen cross-linking, the effect tends to be a lot more. These are our study results, 1-year follow-ups. The other important part is how well do they see. in most of them, the improvement is almost at least a minimum one line from their best corrected, which is with a contact lens, so which is actually quite good. And what is very significant is, and what is they notice is the uncorrected visual acuity. For them, the ambulatory vision almost improves within about 3 to 6 months. You can use toric lenses in keratoconus, and there are two variations in doing it. You could use a phakic lens or a toric IOL. And we have had now almost about 5 years experience in using phakic lenses in keratoconus. There are, of course, very good lenses available, predictable lenses, both locally made, which are hydrophilic, and the Collamer material, which is what we have a good amount of experience with. We have used a lot of these lenses even in patients who've had intracorneal rings and then tend to have significant myopic residual astigmatism, and you can actually debulk it. Remember, they are not a good option for eccentric cones. You need to, if they are central cones or you have centered the cone with the use of intracorneal rings or ablation, then the phakic lens tends to work better. I have seen patients who've had lenses placed in eccentric cones and they are very, very unhappy because you got two toric segments. You got an irregular cornea, which is refracting the light very, very irregularly, and then you got a toric component inside the eye, and it causes a lot of confusion. So it's important that you center the cones, make sure the keratoconus is stable, manage the allergy very aggressively, because a lot of these patients continue to rub the eyes, the effect of the phakic lens will go away. In our studies where pre-collagen cross-linking, pre-phakic lens, the spherical equivalent is almost about close to 9.5 diopters. Post ICL, they tend to have a bit of hyperopia. So now what we do, aim for a bit of myopia if you're using these phakic lenses, but important to note that you do not actually aim for a lot of significant myopia. You may need to leave them slightly probably over a diopter myopic because they prefer that vision. Don't aim for hyperopia, and a lot of them tend to drift towards hyperopia on long-term follow-up. So though we do find if you make the keratoconus stable and then do a phakic lens, the results of debulking the myopic astigmatism even up to about 15 or 16 is possible. An extremely important point which I would probably mention to you is to make sure that a lot of them have a predictable refraction. If a patient has 618, 624 vision and you want to plan to do a phakic lens, it would definitely not be a good idea. I refract all these patients myself. All of them are refracted by me to make sure the astigmatic part is corrected. I'd like to share one other patient who's a software engineer from Oracle in Bangalore, diagnosed to have keratoconus about 15 years back. He's RGB intolerant, he tries scleral lenses, and he's almost consulted all major eye hospitals in India. And he's a very smart bloke. You can see these corneas, which are very, very irregular. In about 10 to 15 years of RGP wear, I'm sure you've seen patients where the whole cornea looks very, very rough. You got a very irregular astigmatism. The patients do not tolerate the lenses. There's a lot of epithelial irregularities. These patients, excuse me, though may look fine in terms of uncorrected and best corrected vision, but they're very, very uncomfortable. I have seen dropout rates with RGPs. Usually in about 2 to 3 years, they stop wearing the contact lenses because they're not able to tolerate the allergy actually worsen. So I have not actually used RGP in the last maybe 12 to 13 years. I prefer specialty contact lenses, which are either scleral or even advanced soft toric lenses. Now, this patient is very smart. He's done intensive research on keratoconus and me. He knows the anatomy of the cornea, the layers, the thickness, even the collagen structure, types of collagen on each layer. He's read all my papers I published. He has a discussion with me on my success rates of achieving the big bubble. He has a discussion with me on interface issues, vascularization, and we basically did a big bubble technique for him. And at that time we were doing it under local. Luckily for him and me, the surgery actually went off very well. In fact, during the procedure, he asked me whether I got the big bubble or not. Luckily for him, everything went off well. This is just showing the standard big bubble technique. I use a 26 gauge needle. You release the bubble and then do a dissection of the posterior stroma, and this works quite well. In terms of outcomes, our results have been published for keratoconus, and they actually do very well. They have good uncorrected and best corrected vision, most of the keratoconus patients. So after surgery, he did well, and post-operatively he was doing well. We removed all the sutures. And after about a year, he has good uncorrected 6/6 vision, but about significant myopia, -10 with 2 cylinders. All sutures were out. And then he asked me, he wanted an ICL at that time. And he, of course, checked. And then he wanted a V4C because he wanted to avoid a PI, which was not available in India at that time. So he emails almost about 4 doctors across the world and asked them about 20 questions about different types of phakic lenses. And I met both these doctors, and they did show me his email, which had a very fairly detailed comparison, asking him to check whether the artisan phakic lens is better or the Collamer lens is better. And then he came back with about 4 gigabytes of literature on a pen drive. And then he gave it to me and he said, "Doctor, you read up and then we'll discuss more." Luckily for him, we did plan and go ahead with the phakic lens. This was the implantation program for him. And post-operatively, he's almost about now 6 years. Surgery went off well. He's got a clear graph with a good vault and a good visual outcome. This is just to show the video, and you can see that for him, I've done a PI because at that time V4C was not available. Of course, now we avoid PIs in almost all our patients. Very clear graphs, all sutures out, and the lens is actually very well placed. We have now a significant number of patients whom we have done post Intacs as well, and it works well if your calculation in terms of placement is very good. This is the other eye, and we are planning for a procedure for him. We did publish our results of DALC, and at that time we did find a lot of these patients tend to do as good as a PK, or at least in terms of visual acuity improvement, quite to be very good. In conclusion, there are multiple surgical options for keratoconus. You can combine collagen cross-linking, intracorneal ring segments, toric ICLs. You can also do PRK with CXL. DALC is a very successful surgical alternative used in combination with keratoconus. And what is important is you can actually give them good uncorrected and best corrected vision. And the long-term follow-up actually indicates a continuity of the effect. Thank you so much. I was told to keep it between about 30 minutes, so I restricted myself so that we have more time for questions.
Thank you, sir. We are open to questions. People can ask their questions after unmuting their mics, and or they can type in their chat. You can ask your questions directly after unmuting your mics. You don't have to type in the chat screen. Any questions related to cornea, not only related to keratoconus also.
I think that's a good question. I have done both, but now my preference is to actually do the PRK first. Usually wait for about 3 to 4 weeks, and then plan for collagen cross-linking. There have been a lot of modification in cross-linking as well. You have now something called customized cross-linking or individualized cross-linking. In individualized cross-linking, you can reduce the amount of energy that is fluence, and this is a concept that has been popularized by Dr. Hafizi, who said that it is possible to treat even very thin corneas by reducing the amount of fluence. and we have done that in a couple of patients. Second part is whether would you prefer to do collagen cross-linking in a single sitting? You can, if the patient is from a different city or is very far off or follow-up is an issue, but I prefer to space it out. I would prefer to do the PRK first, so that the effect of the irregular astigmatism is seen, and then you can actually do the collagen cross-linking in 2 to 3 weeks. If you want to do it really quickly, maybe a 2-day gap would make sense, because it gives you also to see whether you need to top up the ablation and amount of irregular astigmatism. That has been the second question from Mr. Harshit Kataria. Is, any role of oxygen while doing collagen cross-linking? I think it's a very good question, and that is something a lot of research has been done. What we find is usually for the on-off type option, where the C3R continues for 30 seconds and then you switch it off to replenish, is one method of doing it. Whether I use that protocol, the answer is no. I prefer to use the 9 milliwatt 10 minutes, which is the preferred method for me, except in pediatric, which I use the standard 30-minute protocol. There have been some studies in terms of replenishment of oxygen, though it's an important part of collagen cross. I don't think anybody is actually using supplemental oxygen on a regular basis. There is one question from Dr. Dimple. Corneas, which are about 350 microns, can we do a modified collagen cross-linking? Dimple, that's an important question, and I did mention this in my presentation as well. I think what is important is to estimate the amount of collagen cornea which is left after removal of the epithelium. It is now possible with the present protocols and the scans with OCT to actually check what the thickness of the epithelium is. You can then plan it. Even if you have a 300 micron cornea, you can use agents like HPMC, riboflavin, which swells the cornea by between 50 to 100 microns. Important to have an intraoperative pachymeter so that you can check. What is the minimum thickness required? I answered this. If you can bring the thickness to 400 microns, it usually works well. There have been one outcome study by the Agarwal group led by Dr. Susan about using contact lenses, which does give you additional 100 microns. I think it's a good idea, but important to note that the effect of using a contact lens reduces the efficacy of collagen cross-linking by almost about 30%, which was a study done by Dr. Hafizi. So if you can avoid it, it is good, but if it's unavoidable, it's not a bad idea. Earliest age in which collagen cross-linking can be done, it's a tough call, but you know that some people have gone as young as 7 and 8. My youngest patient is about 9, and we could do it under local anesthesia. So it is important in children to make sure that you take them up early. You do not wait for progression. In our nomogram, if I have time, I can share it. In our nomogram, we usually prefer to take them up fairly early for children. We do not wait for progression. For me, it's keratoconus with Ks, which are significantly more, progress more, tend to take them up more. Okay, the question Dr. Bindia is asking about contact lens assisted. I already explained that it is using a contact lens which can allow the UV light to penetrate and then help to give you maybe additional 100 microns along with riboflavin to help you with the collagen cross-linking. Post C3R, there is 370 microns, pre-op 425. What are the treatment options? I use a fair amount of specialty contact lenses. I don't have a name, but it's Galaxy Note 8. I use a fair amount of contact lenses in a lot of these patients. I find that gives probably among the best vision. So I would definitely encourage everybody to use that a lot more. Specialty contact lenses like mini scleral, or soft torics give excellent vision for a lot of patients. We have used them in fairly advanced cones as well. And in a couple of patients where they were unwilling for a very significant intervention, we did just an ablation over the cone and then gave them a contact lens. What are the indications for doing 3 milliwatts, 30 minutes and protocol versus 9 milliwatts, 10 minutes? From Dr. Salim. Dr. Salim, I did mention that in the presentation. if you have a fairly advanced cone or a pediatric patient, I would prefer to do the 3 milliwatts 30 seconds. A question from Dr. Nidhi: how much time do you need to soak the cornea for accelerated C3R full exposure? I think the soaking time for almost all collagen cross-linking is the same. A minimum of 20 minutes, or you put them on a slit lamp and make sure you have or something inside the antechamber. Some corneas tend to absorb the riboflavin much faster, so you just need to be aware of that. Some take a longer time, but usually a minimum of 20 minutes is what my indication would be. Do you follow a question from Dr. Weber? Do you follow the post-op amount of astigmatism stromal haze to alter the amount of energy delivered to the cornea? This is for PRK. That I think that's what Dr. Weber was asking. Now we have a few set of patients whom we have actually done PRK post-CR, wherein the cornea is actually thin. Now, the amount of flattening and stromal haze is an indication of the effect of the collagen cross-linking. We do not alter the amount of energy, but we do undercorrect them. Usual nomogram is about 10 to 15% of what you would normally do. So you need to understand collagen cross-linking corneas tend to ablate at a different rate compared to a virgin cornea where you're doing a PRK-C3R. How many weeks do we use steroids post C3R from Dr. Nidhi? My protocol is usually about 2 months, so I taper it over 2 months. But if the haze is significant, I might actually keep the steroids on longer if it's plain C3R. For PRK C3R, I tend to keep them within about 4 to 5 months, depending on the response of the cornea. You need to watch them slightly closely because a lot of them tend to have significant haze, especially if you're combining C3R with PRK. From Dr. Nayanar, is keratoconus secondary to vernal? If the keratoconus is secondary to vernal, when do you manage the collagen? When do you do the CXL? It's a good question. I think we do know in about 80% of patients there is an associated atopy. Some of them have atopic conjunctivitis, some of them have systemic allergies. So you need to control that. If you have significant vernal keratoconjunctivitis, where you have a tear film which is very, very inflamed, you will have a lot amount of interleukins, cytokines. I would prefer to actually wait before you plan to do a collagen cross-linking in keratoconus patients. A 2 or 3 month period of controlling the collagen, vernal keratoconjunctivitis before you even touch the cornea would be preferable. So at least 3 months of treatment where the eye is not significantly red, patient is controlled. Because if you do it in the acute stage, you are going to burn your hands. We've had a couple of patients who had persistent epithelial defect, which just did not heal. Because the whole environment in a VKC, you got an inflamed conjunctiva, inflamed tear film, it does not help the epithelium heal. Do you use NSAIDs at the protocol immediately or start patients on steroids? NSAIDs in post-op patients for CXL usually is not part of my regular protocol. I prefer to give steroids and monitor the IOP. Dr. Bindya, is there any role for collagen cross-linking in fungal corneal ulcers? It's a good question. I think there have been some studies that is coming out. I did interact with Dr. Hafizi, who was talking about slit lamp attachment for collagen cross-linking, which can be used for infectious corneal diseases. In terms of efficacy, I think we are still very early, and you need to understand that it is not going to work in very deep corneal ulcers. The efficacy, the penetration of what they call PAC CSL, that is of the chromophore activated collagen cross-linking, will not penetrate beyond the anterior part of the cornea. So you are going to look at ulcers which are not healing, which are in the anterior part of the cornea. If you have fungal corneal ulcers which are deep, which are near the descemetes, I would definitely not recommend trying to treat them with collagen cross-linking. In a few set of bacterial corneal ulcers, it seems to work. I think you need to also understand whether UVA, which is used for corneal ulcers, is the correct wavelength. There have been some in vitro and some in vivo studies using UVB and UVC, which has better penetration than UVA. Will keratoconus progress even after treating the VKC? In younger patients, Dr. Nayanar, I would probably watch them very, very closely, because a lot of these patients tend to have a more severe form of the keratoconus. So you need to keep them under closer watch. There is one question from Galaxy Note 8. Please guide me regarding the minimum thickness. I think we addressed this. What is important is what is the thickness at the time of starting the collagen cross-linking. I know some patients have, some doctors have even done very thin corneas like 275 microns as well. I would not recommend that, but using alternative methods like individualized cross-linking, customized cross-linking, or contact lens associated cross-linking, it is possible to treat a lot of the thin corneas. Can we reduce the total amount of laser energy in early keratoconus? Laser energy for PRK, it is possible. You need to adjust the nomogram. In post collagen cross-linking eyes, you need to reduce the duration and the ablation amount by about usually about 12 to 15% is what Dr. Hafizi says. So I follow that. Dr. Vaibhav, do you use customized collagen cross-linking according to the position of the cone using any shields? Okay, now this is a good question. Now there have been newer developments where you can adjust the amount of CXL across the cone. So the steeper part of the cone has more energy, which is almost about 15 millijoules. Remember, we use 5.4 millijoules for a standard collagen cross-linking. In customized CXL, there is a gradient of energy across the cone. So steeper cone in the center and less as you go across. How do you deal with infectious keratitis post CXL? Okay, touch wood, I've never had, though I've managed a couple of patients from other doctors. Now you need to understand what is the cause for the infectious keratitis and what are the common organisms. There have been a couple of published studies in infectious keratitis immediate post C3R. Most of them tend to be bacterial, and if you're looking at bacterial, they're usually contact lens associated. They're likely to be staph aureus. So you would need to treat them with fortified antibiotics. Almost always at least do a smear and culture. If there is a suspicion, you can occasionally get candida as well. So you need to make sure that you hold out the steroids, do a smear and culture before you treat them. What would you recommend as a treatment for central nebular grade opacity post foreign body is giving significant? It depends on the vision, Dr. Monica, in terms of the amount of vision affection and how deep the opacity is. Preferably do an OCT through the opacity to see how deep it is. A lot of time, if it's in the central part, you can probably do a bit of laser ablation to improve the vision. But most of them would have not perfect vision like the other eye, but significantly better vision. If you have an OCT, you can see how deep it is, but you need to be careful while using lasers, because sometimes you may trigger a further reaction. Sometimes the scars tend to worsen as well. So you need to be careful. If we can manage with the other eye and this eye vision is 6.9 plus, maybe 6.6, I would not really touch it.
Would you put a smile lenticule intracorneal creating an intracorneal pocket in a keratoconus patient?
There have been some studies done, and there have been some experimental studies done in terms of using a smile lenticule. It makes sense in terms of adding tissue, but it is almost like doing an additional allograft transplantation. The only issue occasionally would be whether there would be an interface haze or interface changes which would cause, because if you do lamellar keratoplasty, almost all of them tend to have an interface in these patients. So I know that there have been a couple of centers which have tried that. I have no personal experience myself, but in terms of fairly advanced CMCD or even something like a central advanced cone, it might help to increase the thickness, may reduce the central steepness. You may improve the uncorrected visual acuity. You may still require a contact lens or a visual aid. Doctor, the Galaxy Note 8 indication for Intacs. I would probably think in terms of Intacs, we now have fairly good long follow-ups for keratoconus. They've been used in PMD as well, and also occasionally for advanced cones. Now, as I said, they respond better to central cones than peripheral cones, and you need to select your cases very, very well. there is a nomogram for intracorneal rings, both for the standard and the advanced. So you need to select these cases very well before you actually plan for surgery. But you would need them to wear a pair of glasses. You may need them to wear contact lenses, either scleral or toric lenses, to help them see better. But in our studies, you reduce the spherical equivalent by almost about 6 to 8 diopters. A lot of them tend to see better without glasses, and over a period of time of about 2 years, you can actually see a change which actually helps them. Dr. Kaushal asked me, Dr. Anamale, can I just share my nomogram? I think there's a lot of questions on procedure. So if you give me another 5 to 10 minutes, I can just go through my protocol. Is that okay?
Yes, sir. You can share the screen, sir.
Give me a minute.
Thank you. Lysol மேல வைக்கொண்டு அவன் சொல்றான்.
So meanwhile, there were a few questions in the YouTube channel that we had telecast. So they're asking if the rings are getting obsolete with the advent of cares.
I'm sorry, can we just finish, then I'll just check the YouTube channel.
Yeah, sure, sir.
Oh, okay. Can you? How do I share this again? 1 second. Let me just. How do I get? 1 second. All right, I'm going to share my screen now. Can you see my screen? No.
No.
Can you see my screen?
Yes.
So this is my approach for managing patients with keratoconus, or even for that matter, post LASIK ectasia. Now, broadly, when you're looking at managing these patients, you can look at early keratoconus or advanced keratoconus. Now, this is a slightly busy slide, so I will take a bit of time and go over this. Now, if you have early to moderate, that is grade 1 to 3 keratoconus, if it's progressive, you would need to treat. Now, if you got regular astigmatism, you can get good vision with a contact lens. I would prefer to give contact lens if it's not progressive. If it's a younger patient and if it's progressive, I would prefer to take them up for treatment. Now, what are the treatment options? I could do a collagen cross-linking, follow it up with a toric ICL, or I can do an intracorneal ring segment. Now, if there is secondary high myopic astigmatism residual, you can give a contact lens or even plan to do a implantable contact lens. Now, the second part is if you got irregular astigmatism with the picture on the right, you would need to make this central. So you would do an intax. You can use asymmetric corneal segments and follow it up with a collagen cross-linking. Now in advanced keratoconus, where you have central scarring, best corrected vision is very poor, like the picture I showed you. These patients do well with a DALC. If there is no central scarring, fairly advanced cone, you can use hypertonic riboflavin or HPMC associated riboflavin, and secondarily either give a contact lens or a toric ICL. You can use a more severe or more steeper cornea SK, which gives more effect. Combine it with collagen cross-linking. If it's very thin, do a hypertonic associated cross-linking, and a lot of these patients actually do well. So broadly, at which stage the patient is presenting to you, what is the type of cone that you have, almost decides the way that you're going to treat a lot of these patients. I think that is the nomogram that I follow. If there are any questions, I think we can take them up.
Hello.
Is there any questions? How do I?
Sir, one question I had, like, what is the time we wait between corneal cross-linking and toric ICL in patients?
All right. I'm just checking the YouTube feed. How toric for irregular astigmatism? Now, we have been using toric.
Sir, one question. What is the time we wait between corneal cross-linking and toric ICL in patients?
Okay. Now, the question is, how long do you wait before you actually go ahead with the phakic lens? All right. We were initially waiting about 6 to 9 months.
Sir, I think your YouTube channel has to be muted, so it comes with a delay.
Okay. Is that better?
Yes, sir.
Okay. Now the question is, how long do you wait after doing a collagen cross-linking and then planning for a toric ICL? Our studies, initially we were waiting between 6 to 9 months. Then we found that there are refractive changes which occur even after 12 months. Now, my recommendation is to wait between 12 to 18 months. Make sure you get 2 stable topographies, at least 3 to 4 months apart, which do not show changes in keratometry and refraction before you plan for toric ICL. And there was a question from Dr. Kaushal, opinion on intacs with collagen cross-linking or collagen cross-linking followed by intacs. Now, in terms of the present plan, I used to initially do a single sitting for doing collagen cross-linking followed by intacs. Now, over a period of time, we found that this was not ideal because we were not able to predict the amount of changes. So our present nomogram has changed a bit, wherein we do an intracorneal ring segment, wait for about 3 to 4 weeks, because that is the time where the cornea effect is maximum before it starts rebounding. So between 4 and 6, I plan for a collagen cross-linking, either combining it with a PRK because the refractive effect is maximum. And so now it is intact, wait for 4 to 6 weeks, then either do a PRK if the irregularity is still significant, or combine it with just a collagen cross-linking. So the space is about 4 to 6 weeks before the effect of the intact starts going away. So you got to freeze the effect of the intact. Intact's effect is almost immediate. Collagen cross-linking effect takes between 4 to 6 months to completely show. And the effect lasts, in our experience, between 12 to 24 months.
So any more questions from our consultants, fellows, residents?
It takes between 4 to 6 months to completely show. And the effect lasts, in our experience, between 12 to 24 months. How do I take the questions from YouTube?
It is there in the YouTube chat, sir. Chat screen. Just you can.
Okay, now there's a question from Dr. Rajgopal Govindan. An important part which I didn't touch upon is about using cares. Now, I know there's a lot of echo.
Reduce the volume of that YouTube channel, sir. It will come. It is there in the YouTube chat, sir.
Okay. All right. Now, a question that was asked by Dr. Rajgopalan is, are the rings getting obsolete with the cares? Now, cares is basically corneal allogenic intracorneal ring segments, which was a very good concept, which has been started by Dr. Susan. I do not have personal experience with it, but from what my experience shows is, I feel it is indicated in a good set of cases wherein the cone is central occasionally, and maybe for earlier cases, though there have been some presentations recently where they've used it for advanced cases as well. But in my opinion, I would probably wait longer to see the results, because they're almost always combined with the use of collagen cross-linking. If you have a patient only with intact segment or case, you can really see if there is a difference. Ideally, if you can do a match control contralateral eye study, you can really take a decision on that. I feel it is a promising option available now, but I would wait longer before I adopt it. Dr. Devipriya mentioned about results of PRK with collagen cross-linking. We've had now almost 24 to 36 months results of combining these two procedures of PRK with collagen cross-linking. Works very well with eccentric cones, with central cones, and all of them usually have an improvement of 2 lines of uncorrected vision and about 4 to 6 lines of best corrected vision. So I would actually keep that as a primary procedure for grade 2 to 3, which is early cones. Logically speaking, CXL should stabilize in PRK. That's a question from Dr. Rajgopal. I used to think like this as well, but I find that if you do a PRK, you can correct the irregularity and then freeze it with the collagen cross-linking, because collagen cross-linking leaves the irregular cornea irregular. It does not improve the irregularity. So they would still require a glass or contact lens, and it's extremely difficult to correct them with a pair of glasses. If we follow the procedure which I do, which is to do the PRK first and then do the collagen cross-linking, a lot of them actually see well with a pair of glasses. Epi of CXL in children, how do you manage the postoperative pain? And as you know, it is quite painful for the adult. Now, the important part about using epi of collagen cross-linking, both for children and adults, is how you remove the epithelium. We have almost totally stopped manual removal with the use of blade. We use majority of the time a PTK, which is very, very comfortable for the patient and for the doctor as well. And you use a 8mm zone size. A lot of them actually do quite well. We've not had issues with pain even for PRK combined with CXL. And we have done now 6 months follow-ups with the new PTK mode for a lot of these patients. Dr. Kothari, how do you use mitomycin for PRK with CXL? I do use mitomycin partly to prevent the scar and also to prevent an excessive scar reaction, which can occasionally occur. Like with all refractive cases, you really don't know which of these patients are going to have significant haze or scar post-op. If you can modulate it, it would be very good. Then you can actually treat the refractive part. But mitomycin is to prevent an excessive flattening or a hyperopia, which occasionally occurs in some of these patients. How do you monitor the progress after C3R? Now, this is a very good question, and there have been fair amount of expert opinion on how to say if a patient is progressive or if the keratoconus is stabilized or it is actually reducing. My nomogram in terms of using these parameters is you need to have repeatability of any machine. Remember, for the same patient, if you do topography or shine plug, even 1 day apart, the average change is about 0.5 diopters. So you need to have repeatable scans, that is primary. You need to have a good optometrist who's doing it, or if you're doing it yourself, make sure the scans are repeatable. For me, there are two things. One is the uncorrected and the best corrected vision, the refraction which the patient accepts, and also the scans. For me, any pediatric change more than 0.5 and adult change more than 1 diopter is an indication either for treatment or in terms of improvement. So I keep my cutoff as at least about a diopter of a steep K changes or astigmatic changes of at least of a diopter. That is my cutoff. Okay, Dr. Hemobindu's question, do we need to modify the intensity and the power of UVA according to the K values and pachymetry? Now, this is a good question, and this is probably where we are going towards what we call individualized collagen cross-linking. The protocol that we followed till recently was that all one size fits all. Now, what we are finding over a period of time is you can actually reduce the intensity for UVA for very steep corneas. You don't need to go the full length. You don't need to give the 5.4 millijoules. Most people now, we are waiting for the paper to come out, but at least discussions with Dr. Hafizi, who worked on this protocols, mentions that you can reduce the fluence from 450 microns even up to 250 microns according to the thickness, and it will be a nomogram, it will be a table which you can print and keep it in the operation theater and just draw a line and do it. So that should be possible. There's a question by Dr. Swaroop Reddy. For PTK, how many microns do you ablate for PRK or C3R? Now, I have access to a machine which gives me the epithelial thickness in all my keratoconus patients and even my LASIK patients. So what I do is a lot of them, I put them on the OCT, check the thickness, and then plan for the PTK. As I told you, we have access to a customized PTK option where you can ablate as per the patient's requirement, which is maybe 30 to 40 microns, 50 microns if it's a normal thickness, and then start the treatment for the PRK or the customized ablation. Now you need to understand there are two ways of doing treatments for collagen cross-linking when you're combining it with a laser. You can do a refractive correction, which works quite well provided you take care of the astigmatic part and the irregularity. The second way is to only treat the irregularity, which I mentioned in my case presentation, which is a topography guided treatment, wherein the irregular parts alone with a bit of refraction is treated. Now for central cones, I always almost treat more of the refractive part. For eccentric cones, which are cones off the visual axis, I would treat more of the topography guided. So that is a protocol which I do follow.
What about use of alcohol for removal of epithelium?
It works well, but I find they tend to be more symptomatic post-op. You can use the Amoy's brush, works less painfully, because when you put alcohol, which is a chemical, you do inflame the conjunctiva, you do cause a bit of reaction in the corneal stroma as well. So it is not my preferred choice, but if you don't have access, it is reasonable. We did that for many, many years. A question from Dr. Swapnil. What is your experience with customized collagen cross-linking? Now, customized collagen cross-linking is what I mentioned. You have variable energies across the cone. You have maximum energy at the tip of the cone where the ectasia is maximum and a graded amount of laser or UV light across the cone. It seems to work well in selected patients. I have seen only a couple of patients who've undergone that. I personally don't have access to it. I feel it would work well if you have access to it. Now, with the present software, even on some machines like Swin, you can do customized ablation of the steepest part of the cone. Earlier, we had to ablate the whole cornea, but the present protocol and software upgrades allow us to actually treat only the steepest part with the laser. So that's a progress which we have seen. So I think all of it now, collagen cross-linking, what we started with about 14, 15 years back to where we are, it is shifting towards individualization and customization based on the site of the cone, the amount of the ectasia, and the amount of energy to be used. I think that's where the future is. Next 4 to 5 years, I feel we would be doing a lot more of ablations and doing only focus part of the collagen cross-linking for the ectatic part. We may avoid treating the normal part of the cornea. Maybe only for the zone of treatment is going to come down. In LASIK, we were planning for larger zones. Going forward, I think the zones of treatment for collagen cross-linking and lasers for keratoconus are going to come down. So you're going to treat less and less of the cornea as we go forward.
Thank you very much, sir, for your enlightening lecture. So you have answered a lot of questions, in fact, all the questions. And in case if we are not having any further questions, we can close the session.
Okay, all right, quite informative. I think, how do you, just maybe one last question from Dr. Mayank. Trans PRK, how do you see need for Intacs? Do you customize abrasion in trans PRK and 470 micron? Your protocol for TREC and steroids, do you mean Parthasarathy? That's almost about 5 questions. Okay, now let me just take that very quickly and then I'll close, Dr. Anand. Thank you so much. So post-trans PRK, I have almost never done Intacs. You don't need it because these are used for predominantly moderate cones in which the response tends to be quite good. So you would not require additional treatment with the Intacs. How do you customize the abrasion? Customize the abrasion treatment in trans PRK in 470 microns? All of these patients have a wavefront adjustment done. You would need to look at what are the significant aberrations that are causing the drop in visual acuity and also combine, do a good refraction. All of these, Dr. Mayank, need to be refracted by yourself. My protocol for TREC is, I basically, unfortunately, I would not show that, but in terms of TREC, you need to measure the size of the cone. This is what I meant in terms of customized ablation for keratoconus. A lot of these patients you can customize the steepest part of the cone by shifting the laser beam to the steepest part of the cone. That's what TREC is. TREC basically stands for topography guided epithelial removal. And it's similar to a PTK, but in this you shift the ablation to the site of the cone, and that actually responds quite well. And this last part is in terms of steroids. You can use PRED, or I use like this. Other option is to use DEX or Lotipred. Depends on the response. PRED can be used provided there's no IOP response. Monitor the IOP. The last question is role of cycloimmune drops. If you have significant dry eyes and allergy, immune drops or cyclosporin tend to have a role. Vitamin D as a primary treatment, no, but I think now vitamin D is almost in every specialty, so I don't think there's any harm in doing that. Whether it makes a difference of the keratoconus, I'm not sure, but it will definitely help the dry eyes. I think Dr. Annamalai, I thank you so much. I thank Dr. Venkatesh for inviting me. I have had a fantastic time and I look forward to many more sessions and attending it as an audience as well.
Nice. Suma here. It was very nice. Thank you.
Thank you very much, sir. We'll close the session and look forward to further meetings with you.
Thank you so much. Have a good day, all of you, and stay safe.